Welcome, caregivers. This is Bonnie Quasney from Home Care Angels. Today we are going to talk about Home Care Angels caregiving for hip and knee replacements. Now, the purpose of this training is to educate you on how to help and assist clients who are coming home after hip and knee replacements. We've been doing this as a short-term job, sometimes for caregivers, sometimes the length varies depending on the client. And this training has been made to help your understanding of our non-medical limitations, but your so important role, focusing on their safety and using the direction from their physical therapist, their occupational therapist, and the physician. So what is a joint replacement? It's a medical procedure that removes the arthritic or the damaged joints, and it replaces them with a metal, plastic, or a ceramic device, and we call that a prosthesis. You know, you can do many other joints, but today specifically we're going to talk about hips and knees. So why do people choose to have this as an elective procedure? Why are joints replaced? You know, think of it. The joints aren't working the way they used to be. Unfortunately, part of aging, is wearing down on our joints. Pain is the number one reason people have this surgery, and it gets to the point where it interferes with just their daily activities. You know, their walking, their stairs. Also, there's a lot of people that enjoy part of their outside activity is maybe playing tennis, bowling, golfing, and things they enjoy they can't do anymore. You know, it can get so bad that showering is a problem, dressing is a problem. Now, keep in mind, sometimes you will have a client that had a fractured hip, or very rarely a knee, but remember the hip is the most common joint that's broken, bone that's broken after a client falls. So the care would still be the same, and that's, also a reason why a joint is replaced. So the number one reason is pain. If you've talked to anybody or you have pain yourself, it gets to the point where my quality of my life is just not what I need it to be. So some of the key factors about a knee replacement is our knees are the largest joint in our body, connects your upper and your lower leg. And over time, we have a cushioning material in our knee joint, and it can decrease. You might even hear people say it's bone on bone because it's lost that cushioning material. So during a knee replacement, implants will replace the knee joint itself. Now, usually the ligaments of the knee and the muscles of the knee are not involved. This still allows your knee to bend the way it should be, how it was meant to be. Now, a visiting nurse will come in and she will be the one to change that dressing. This is something you might see when the nurse changes it. There will be very often metal sutures. It's going to be red, it's going to be swollen, and some discoloration like a bruising. Now, a hip replacement, some of the key facts when you have a client that had that, our hip joints support most of our weight during all movement that we make. And in that hip joint, there's cartilage, and it can, and it does, as we age, some people more than others wear out. There's different types of hip operations that it's the orthopedic surgeon's decision to do. And some are a little easier to recover from. I'll just tell you a little later on so you know what you might see when you have a client. This is what the hip joint might look like when the visiting nurse takes off that dressing. So you can see the same. It's red, it's swollen, it's discolored, it's got some sutures in it. Your job is to leave that dressing and the nurse will take care of it. So I let you know there's different types of hip replacements The posterior, the back, which is more towards the rear end, the hip joint, that was like the traditional way. You know, the surgeon cut through some muscles. It was a longer surgery, a longer recovery. So naturally, there was more pain and different instructions. Now, the incision may be, and that's a surgeon's decision, more towards the front. The idea of them doing it there is they have to cut through less muscles. You know, so fortunately, it's easier for them to recover and less pain. Now, before they're discharged from the hospital, they will have specific goals that the patient, the client, has to meet before they're discharged. They have to get out of bed in the hospital sometime that very same day, sometimes the next day, with an assistive device, meaning a walker. They have to be able to keep their food down, drink normally. They have to be able to use the restroom, meaning they're able to urinate and they're physically able to get there with help. They're physically able to get on and off a toilet with help. The client has to maintain their vital signs, meaning their oxygen has to be fine, their blood pressure and pulse has to be normal, and they have to be able to tolerate pain with the medication that they'll be discharged home on. Let's say their pain has to be managed because they are going to have some pain. Some of these people too, they'll even try them on some stairs before they come home. But this is all care that client will have to meet before they come home for your care. So after your client, whether it's a knee or a hip, is discharged home, your job will be assisting them in a lot of different areas, you know, and there are important things for your care. And some of these important things to keep in mind are, client, you'll be helping them with pain management, swelling of that surgical area, preventing them from getting dehydrated, activity, knowing that they're a fall risk and helping them avoid any falls, and helping them and being familiar with the equipment that they're going to use. Pain medicine, you know, one of the biggest reasons somebody's chosen to have a joint replacement, we talked about, is the pain. But they're definitely going to have pain. Sometimes they don't always have pain on day one, you know, and people can vary. Some people's tolerance of pain varies. And sometimes these people will have lingering effects from the surgery they just had, the general anesthesia, and possibly the stronger pain medicine that they got in the hospital. So I want to talk to you a little bit about safety on that end. So they may not be in the same kind of pain, or they may have a lot of pain, but you will definitely need to help them in and out of bed, on and off the toilet, and dressing and bathing. So you're going to be doing those medication reminders to help that client stay ahead of the pain. Stay ahead of the pain means, let's say the surgeon says, take your pain pill every 3 hours. You know, some people tend to be so stoic. Oh, I'm going to wait 4 hours. I'm going to wait 5 hours. Just remember that pain is a lot harder to manage, to keep under control, if people wait till it gets to be excruciating. And just like our other clients, we can't open any of these people's pill bottles or set up the medications. They certainly can do it themselves, or if we know they'll need help, we'll talk to the family ahead of time. Now, their pain medicine and just being post-surgical will have some side effects that it's good for you to know about. They're all going to tend, most likely, to be constipated just from having surgery itself and from getting strong pain medicine. They may be nauseated, you know, maybe from the pain medicine, the anesthesia. Their appetite might not come back right away. They may be still a little sedated from the surgery, the anesthesia, the medicine. They might be drowsy. They might be foggy, like their thinking is clouded. And if somebody is really still sedated from the pain medicine, even their breathing, may be slower. Those are all things you're going to keep an eye on. Especially with your older client, especially somebody right out of the hospital. I want you to think about those side effects that pain medicine has on people, and think about some tips for added safety care. You never want to get them up too fast, whether you're getting them up out of bed, they're sitting at the side and you're going to a standing position, or getting up from a chair to stand. You just want to take it slow. You want to have them look up at you. You don't want somebody hunched over, their head down to the chest. You want them to have their eyes wide open. They're going to look at you. You can have them take some nice, slow, deep breaths before they stand. And definitely, if they look lightheaded, just keep them seated for a minute. Maybe you want some more deep breaths. Maybe you want to get them a deep glass of water. Just don't rush them to get back. Because what could happen, they could go down on you. Worst case scenario, let them sit for a bit and come back in a little bit. They are going to come with swelling of that surgical site, both in their knee and the hip, and that's normal. But look, like this picture, this person has swelling, and it's normal, even below the knee, the ankle, the foot might be swollen, the thigh might be swollen. If you look close, you can see some bruising. It's a little discolored and reddened. Those little strips, a lot of times they cover the sutures. They call those steri strips. But again, this is what the incision will look like possibly after the nurse comes and takes off the bandage. What you could be involved in to help keep that swelling down is, it's important for them to avoid long periods of walking, meaning overdoing it, or sitting them too long. That leg will be elevated when they lay down. There's nothing wrong with taking an afternoon nap or just resting in bed, elevating it. The therapist will discharge instructions, will tell the client about icing it. Usually it's 20 minutes a day, several times a day, and they'll make sure that they have something ahead of time or send them home with something to ice it. They will only perform exercises after they're seen by the physical therapist. So that's another big point to stress. You're going to get them up to walk a few steps, but anything further than that, as far as exercising, will come when the therapist and or the nurse start. You're going to keep an eye on how much they're drinking, because it's so important. We're always getting those people trying to get them to drink enough, but especially after surgery. It'll help with their healing process. It's very rare, but orthopedic surgery has a possibility of a blood clot. So it's going to help decrease that chance. It's going to help keep away an infection. And it's also good to drink anytime somebody's had anesthesia to help remove the toxins. And it's going to help their medications go down too. And they may start out slow on a liquid diet even. We just want to make sure they get water and liquids in. Their appetite will slowly come back if it's been like that before. You're going to be involved a lot in their activity and their movement. Just like every other client, they're all going to have different limitations. And that's why this part is in bold. And I'll probably say it several times. We're always going to follow the physical therapist's instructions. They're the ones that are going to bring a list of a routine and exercises, talk about the weight-bearing limits, the do's and the don'ts. And we are never going to do any of these exercises until we're told by physical therapy. Usually the visiting nurse and or therapist should come the next day, but no It's not always on the day of the surgery. And like I said, hopefully it's the next day. You know, in the meantime and throughout the time you're there, we're going to be real careful about fall risk. They are a high fall risk. You know, anytime somebody's got a physical limitation, we're always putting them at a higher fall risk. They are at a higher fall risk. And it just makes it worse of a chance. So even if they want you to, they think they're Superman, they do not get up without your assistance. They are always shadowed, meaning we're always going to walk with them whenever they're walking or exercising, and they're going to have a gait belt. What you can do, as you do for all the clients you take care of, you're going to look around for fall risks. You know, you're going to be really careful about tripping hazards in their house. They were told about this ahead of time, but definitely take a look out, you know, like the rugs, maybe they got a pet, cords in the way. Kind of picture a path between where they're going to be walking and eyeball it that it's clear. Hopefully they got really good lighting, and you know when they're in bed or they're sitting in a chair, keep everything they're going to need close. You know, the Kleenex, the telephone, remote control. You're going to have people maybe are the opposite. They're going to get up to get the TV remote because they didn't want to bother you. So that's another way that you can keep them from falling. Be a step ahead of them. Part of your job is going to transfer them in and out of bed. Both these pictures could be the knee and the hip client. The shaded area on the client on the top, that's his surgical leg. So we're going to try, and hopefully the bed is positioned, and PT is the expert on how to do it. Get out of bed on the same side as their operated leg. They're going to be taught in the hospital how their hands are going to be used and how the leg on the unoperated side is going to be used. Most likely you are going to be supporting the leg that had surgery, because just swinging it in and out of bed is going to be hard for them. So your job is going to help keep that leg stable. Now think about it ahead of time. I don't want you, you know, the client might start that first effort to get bed and make a big, you're not going to, I don't want you to bend over right away. I want you to anticipate it so that you're ready to use your legs, not your back, to help that client support that leg to get back into bed or out of bed. They're going to have some equipment in place at home or come home with it. You know, when it's whatever equipment the doctor wanted, the physical therapist told them they should get, and they can vary, but we're always going to use a gait belt. They're going to have a wheelchair or a walker. Hopefully they got a raised toilet with arms. It's so much easier when they can use their arms and they don't have as low as the ground to go. They might even come home with a grabber, you know, because they're not going to be doing a lot of bending and reaching. Like I said, a lot of these people are going to be coming home quicker after their surgery. Think about it, especially with COVID going on. A lot of people used to go to rehab maybe 1 to 3 weeks, you know, just for a short time, but they're bypassing that rehab facility now. And it's a big decision, you know, because of COVID. But the first 48 hours of their time at home are really important. And you're a big, big part of that. You know, home health, like I said, will come in, but it might not be that same day, you know. We don't know. So it could take a following day. So very often you are the one that's going to be there first. Always following what the surgeon's orders are, the physical therapists. And like we talked about, they're going to come home with a written piece of paper with their discharge instructions. So if they come home with a pile of stuff, help your client pull that out and you can review it with them. So the things you're going to do with your client right away, right off the bat is, they're going to be exhausted. You're going to be a big part in telling them, boosting their confidence. They're going to be overwhelmed. They're going to feel very dependent on you. They're going to be in pain. So you're going to let them know that, yes, just getting out of bed is good for you. Yes, the pain medicine will help you. Yes, you're going to get better every day. You're going to help them keep up with the ice to keep that swelling down. You are going to be the encourager and avoiding them sitting for longer than 45 minutes, 60 minutes tops. And remember, in the beginning, before therapy comes, you're still going to get them out frequently, but short walks. Walks to the bedroom, walks just a few in the living room, walks in and out of the bedroom. There's not too many people, but don't let them do any heavy lifting. And you're going to make sure they are using their walker they were told to use. Now, specifically for a knee, there's a few things to avoid. There's things that are common for everyone besides what the surgeon and the therapist say. You're not going to have them sit too long, that same 45 to 60 minute time period. I don't know who's going to want to do it, but no squatting. Think about where they're going to spend a lot of their time. I hope they have a nice, firm, high back, comfortable chair in place, because we don't want them on a sofa. For one thing, they're usually soft. And the other thing is they only got one arm. So we don't want them on a really soft, low chair. Think about the trouble with a rocking chair. Something firm, comfortable with two arms. A pillow for a knee replacement client is a little different. We want to avoid putting that pillow right under the knee joint. The reason being, if you think about a pillow under there, it may flex that knee a little bit, and we want to prevent any of that contracting, the knee flex. So go ahead and put the pillow more under their lower leg, under their calf and their heel. Don't let them jerk, twist, or pull the knee. Don't let them run. Certain things are common for all hip replacements, just like a knee. So again, we're going to follow what the therapists say, but there's some common things with that hip replacement client. This gentleman in the first picture should not be leaning forward. They've got to sit up straight after hip surgery. We don't want them bending forward at all. Think about it. They're bending at the waist, right at that hip surgery where we don't want them to. They absolutely should not cross their legs, whether they're sitting in a chair, whether they're in bed. Some of us are just in a habit of crossing our legs. So you keep an eye out and you're going to remind them. When they're ready to walk, when they're standing, look down and you can get in the habit of reminding them. We want their feet to point straight ahead, straight in the direction that they're going to be walking. Not turning in, not turning out. People turn their feet in, we call that pigeon-toed, but we want theirs straight out. And every surgery has some risks. They are rare, but it's good for you to know that you're going to let us know if they have severe pain. The pain or swelling in their leg is not related to their surgery. I mentioned that orthopedic surgery has a higher risk of a blood clot. So these are things that are rare, but we're just going to keep an eye out if their calf is tender or red. Very commonly, people might be discharged from the hospital with a temperature of even 99. It might get raised a bit just from surgery. But we definitely don't want them to have a fever. You would call with any shaking or chills. If you notice that there's a lot of swelling or redness and it increases, or if the bandage gets saturated or it's draining. These are all important things that you'll keep an eye out for. And just know you are there because we know you are a big part of helping them recover and that we're always here with you. If you have any questions, any issues, you give us a call anytime. Thank you.
Joint replacement surgery can be a positive, life-changing step towards significantly reducing pain and increasing your mobility. But before your surgery day, there's something important you need to do to prepare. Getting your home ready for your return from surgery will give you peace of mind and help to ensure a safer, more productive recovery process. First, take a tour of your home, paying attention to the things you typically overlook, such as the number of stairs, door sills, and other hurdles getting in and out of your home, as well as getting around inside the house. You can't necessarily eliminate these fixtures, but you can be more aware of what's in your path and determine the easiest and safest routes. If you must climb steps to enter your home, your physical therapist will teach you the proper technique. And speaking of stairs, create a first-floor sleep space. If you live in a 2-story home, you'll want to sleep downstairs for the first weeks after surgery. Next, zero in on trip and fall hazards. You'll be using a walker during your recovery. To make it easy to move throughout your home and to reduce your risk of falling, remove all rugs and tuck electrical cords away from walkways. With the help of a friend or family member, rearrange furniture if necessary to allow a wide path through the rooms of your home. While you're rearranging furniture, think specifically about identifying the right chair for you. Make sure you have a chair with sturdy arms that you can use to help you stand up and sit down after surgery. Place a small table next to your chair so you can keep essentials such as a phone, television remote, and your glasses within easy reach. Make sure your chair measures up. Measure the chair and/or couch and acquire cushions or firm pillows that you can sit on to ensure that your knees are always slightly lower than your hips. This is important because while you recover, you will not be able to bend your hip joint any closer to your body than at a 90-degree angle. And finally, as you prepare your home, there are a couple more steps you can take to make life a little easier for yourself later. Keep everyday items handy. Place things that you'll know you want to reach often, like clothes, dishes, or bathroom toiletries, in new locations, so you can reach them without bending down or reaching up. Look into assistive devices. Your home medical equipment store has devices to make it easier for you to use the toilet, bathe, dress yourself, pick up items, and get in and out of a chair and your bed. Equipment most often used includes a walker, shower chair, raised toilet seat, sock aid, and a reacher to help you grasp low or high items safely. Ask a friend to care for your pets. Furry friends are wonderful, but they can also be a trip hazard when you're recovering from surgery. For your safety, consider asking a friend or relative if your pet can come and stay with them during the initial phase of your recovery. Once you've taken these steps to prepare your home, you'll feel more relaxed and confident as your surgery day approaches.
You may be able to get in and out of bed by yourself after your knee replacement, but sometimes you might need help. If it is difficult or painful for you to get in or out of bed, having your caregiver there will make it easier. You can sleep on pillows to raise your head and upper body. Never put a pillow underneath your knee while you're resting in bed. Put blankets or firm pillows under your ankle to decrease swelling and to help your knee heal in a fully straight position. You will practice bending your knee when you're sitting and completing the exercises. First, we will show you how to get out of bed in the morning. Prop yourself up on your arms. Bend your non-surgical leg and push with your heel to help you move to the edge. If it is painful to move your surgical leg, your caregiver can help by putting one hand on the back of your leg above the knee. The other hand should be placed on the back of your leg on your calf. This provides good support for your knee. Your caregiver should be close to you and bend their knees and not your back while helping you. You can move one leg at a time to the edge of the bed. Once you are close to the edge, scoot forward to place your feet on the floor. Your caregiver can continue to support your leg as needed. Try to bend your knee as much as you can to get your foot flat on the floor. Your caregiver should put your walker in front of you. Push up from the bed to stand, then reach for the walker. Once you stand up straight and feel steady on your feet, you are ready to begin walking. Now, we will show you how to get back into bed at night. Back up to the bed until you feel the back of your knees touching the bed. Reach back for the bed to slowly lower yourself into sitting. Put your hands behind you on the bed and scoot backwards at an angle towards your pillow. Your caregiver can help you lift your surgical leg up onto the bed. Bend your non-surgical leg and push with your heel to help you move up in the bed. If needed, your caregiver can continue to help move your leg. Put blankets or firm pillows under your ankle to decrease swelling and to help your knee heal in a fully straight position. Never put a pillow underneath your knee while you're resting in bed. It can be difficult to get in and out of bed if your mattress is high. You will need to get a sturdy step stool. It should have rubber tips on the legs so it does not slide on the floor. It should also have a non-slip surface to stand on. Do not use a children's inexpensive plastic step stool. These are not sturdy enough for adults. Once you are seated at the edge of the bed, have your caregiver put the step stool in front of you and give you your walker. Push off of the bed to stand up on the step stool with both feet. Then hold on to the walker in front of you for support. Push the walker in front of you and step down with your operated leg onto the floor. Then step down with your non-operated leg. You're now ready to walk with your walker. When getting into bed when your mattress is high, have your caregiver put the step stool by the head of the bed, about a foot below your pillow. Walk with your walker to the step stool and turn around so that the step stool is directly behind you. Step up backwards onto the step stool with your non-operated leg while using the walker for support. Then step up onto the step stool with your operated leg. You will now be standing on the step stool while using the walker as support. Reach back for the bed with one arm to support yourself as you sit down slowly. You are now ready to lie down in the bed.
How's your pain doing? Are you having any pain?
Prior to getting the patient out of the bed, always check to make sure the bed wheels are in a locked position. Make sure that you ask the patient's permission to undrape them. If the patient gives you permission to undrape them, remove the drapes out of the way so that they do not get in the way of the transfer. Next, go over the hip precautions with your patient. Remember to tell them that no hip flexion past 90 degrees. This can include them bending down to touch the floor or using the restroom without a raised toilet seat. Next, go over no crossing the legs for adduction of the hip. This can include any sitting and crossing the legs or crossing the legs while trying to roll in the bed. For them to be toeing in, make sure that there's no internal rotation going on. Rolling in bed is a contraindication for this.
You cannot flex past 90, so that means you can't bring your knee up and you can't bring your head down, okay? And that also means you can't, can you see my legs? Okay, you can't bring your leg in past the midline, okay? And so no crossing your legs, no crossing your ankles. And then you can't internally rotate. So no rolling those feet in towards each other, okay?
Once the patient understands their precautions, give clear and concise instructions on how the transfer will occur. Here, we are going to do a supine to bedside sitting transfer. First, ask the patient to push up with their arms into a long sitting position. Explain to the patient that you will hold their affected leg and move with them as you have them rotate towards the side of the bed. The patient is allowed to use their unaffected side to assist with the transfer. Have the patient move towards the edge of the bed by scooting forward to prepare for the sit-to-stand portion of the transfer. Prior to getting the patient in the wheelchair, check to make sure that the brakes are locked. Remove both leg rests so that they do not get in the way of the transfer. You also want to check the height of the wheelchair to make sure that it does not break the hip precautions for the patient. Adding a pillow will increase the height. Apply a gait belt to the patient to ensure safety throughout the transfer. Ask the patient if there are any lines or tubings that may be occluded by the gait belt. Prior to the transfer, move the Foley catheter from under the bed to the wheelchair, ensuring that the Foley catheter does not touch the ground and any lines or tubings do not get pulled during the transfer. Miss Monroe is weight-bearing as tolerated and weaker on the affected side. She has full strength on the unaffected side. During the transfer, we will guard the affected side in case her knee buckles. Prior to the transfer, explain to the patient that they can push up through their upper extremities and move into standing as the patient counts to 3. You will perform a pivot transfer, continuously guarding the affected side. Then explain to the patient to reach back on the armrest of the wheelchair to assist in sitting. Having the patient keep their affected leg extended helps to prevent hip flexion during seating. Once seated, the leg rest can be placed back on the wheelchair. Prior to transferring the patient back to the bed, make sure that the wheels are locked on the wheelchair and remove the leg rest. Then transfer any lines or tubings back to the bed. Ask the patient to scoot forward towards the edge of the wheelchair to prepare them for the wheelchair to bed transfer. Guard the patient's affected side and ask the patient on their count of 3 to push into a standing position. Using a pivot transfer, rotate the patient towards the bed. Continuously guarding the affected side. Have the patient reach back and scoot theirself onto the bed. For the bedside sitting to supine transfer, remove the gait belt and explain to the patient to use their arms to help push themselves back into the bed. Explain that you will be supporting and moving their affected leg through the transfer to prevent breaking hip precautions. Then have the patient rotate towards the head of the bed. Prior to leaving the patient, make sure the head end rails are up and the head of the bed is at 30 degrees or more. The patient's seat should be lined up with the fold of the bed. Place a pillow or roll between the knees to prevent hip adduction. Leave the patient with a call button for their safety. Their tray in reach, and ask the patient if there is anything you can do to make them comfortable.
Swelling can persist for several months after surgery. To manage the swelling, it's important to elevate the leg and avoid sitting or standing in one place for long periods of time. Some people also experience bruising after surgery. This is normal and will disappear with time. In terms of your incision, you can expect some redness, but it should not be expanding. Your sleep cycle may be off because of pain or the need to shift at night, and your sleep may come in chunks. If you're waking up at a predictable time at night because of pain, talk to your doctor or pharmacist to see if you can adjust your medications to get ahead of the pain. Feeling down. Now, I think having a joint replacement is a major life event and involves some hardship for sure. So I think feeling blue at times is normal, but feeling sustained depression is certainly not. So talk to your care team or your family doctor if you feel overwhelmed. Finally, you will be taught certain exercises in the hospital, and it is crucial that you do these. Most of these you can do on your own. After knee replacement, it is imperative that you work hard on getting your knee range of motion quickly. Most people require the help of a physiotherapist in a clinic setting for a short period of time. After a hip replacement, your surgeon or care team may outline a few movements that they do not want you to do. Rapid recovery typically occurs in the first 3 to 4 months after surgery, but you can continue to improve for up to 1 to 2 years. Number 4 is about making your home safer and easier for urality post-surgery. Clearing out space so that it's easy to get around with a walking aid, and removing small area rugs that might cause you to slip. Your balance may be off after surgery, so be extra careful not to rush and trip and fall. It is a good idea to have somebody around for the first few days as you get used to the new normal. Before surgery, you can purchase some helpful items for the first 3 months, including a long-handled shoehorn, a sock aid, a long-handled reacher. People with hip replacements may want a firm foam pillow for chairs and a raised toilet seat. All these things sound like a drag, but they'll actually increase your independence. Number 5 isn't a thing, it's an attitude. Henry Ford once said, "When everything seems to be going against you, remember the airplane takes off against wind, not with it." I always thought that was true of having your hip or knee replaced, enduring some resistance so you can take off. It'll be a lot easier if you can balance optimism with realism, ask for help when you need it, and keep an eye on the big picture of improvement. Thanks and good luck.